The anatomy and the pathology of the brain can best be appreciated by actually directly looking at and inspecting the brain. So if we take the brain and actually take a look at it, inspect it, dissect it, divide it into its parts, we can actually go a long ways to figuring out what's going on if there's a problem with the nervous system. In fact, the whole reason for learning neuroanatomy, neurophysiology, neuropathology is to be able to understand what's going on with the brain and to be able to solve problems, clinical problems. The first principle for clinical problem solving is that of anatomical or regional diagnosis. Well, the best way to accomplish that is to actually directly inspect the brain and look at it. How can we do that if this brain is within the skull of a patient? The answer, the window to be able to look at this brain is the neurological examination. The neurological examination is so much more than just a long list of tests and maneuvers that one must do on physical examination. The neurological examination, if approached in a logical and systematic fashion, can actually help us to know where the problem is. It helps us by looking at anatomical levels as well as systems to be able to localize where in the nervous system is the problem. I think you can get a better idea of how we can do this if we were to use a mathematical model, that model of an XY graph. We know that if we have y values and x values on that graph, then we can localize where the problem is or where the point is that we're interested in. For example, if we had a y value of 4 and an x value of 2, then we know exactly where on that plane is that particular point. Well, we can think of the neuroaxis very similar to that XY graph. If we take the brain and superimpose it over that XY graph, we start to realize that the nervous system is organized in a vertical dimension. We have structures such as the cortex, the cerebral hemispheres, the brainstem, the cerebellum, and the spinal cord, as well as the nerve roots, the peripheral nerves, and the muscles, that all can be used as Y points on our XY graph. So we can start to look and localize where things are going on in the brain as we look at these vertical levels. But we only have one dimension. We need another dimension. I think you can appreciate how we can do that if we just rotate the brain, instead of a lateral view, rotate it 90 degrees and looking at a coronal view. As we look at a coronal view of the brain, we realize that the structures within the brain and the spinal cord can be looked at with respect to right and left and midline. So most of the structures within the brain are either right-sided, left-sided, or midline. We have X values now. So in combination with our vertical levels, as well as then our right, left, and midline, we start to then develop XY coordinates as far as where the problem is. Now, we need to add 3 longitudinal systems, which will help us as far as obtaining more Y values as well as additional X values. The first system that we need to be able to inspect and look at is the descending motor system, the upper motor neuron in combination with the lower motor neuron and their connections. We know that the upper motor neuron starts on one side on the cerebral hemispheres, descends to the level of the lower medulla, crosses over, and then continues its descent through the spinal cord down to the lower motor neuron, and then of course the lower motor neuron, its connection through the peripheral nerve and the muscle. So we now have some more valuable Y and X points. The 2 ascending longitudinal systems that we need to be able to be aware of what's going on are the sensory systems, divided into 2 components. The spinal thalamic, which serves the sensory functions of pain and temperature, and the dorsal column medial meniscus system, which is for position sense as well as discriminatory sensation. Now, two important anatomical and hence clinical points that we need to be aware of and to think of that help us as far as localization are as follows. As we look at the spinal thalamic tracts, they enter the spinal cord and cross almost immediately to the opposite side and then ascend up to the thalamus and on to the cortex. On the other hand, the dorsal column medial meniscus system does not cross immediately. In fact, it doesn't cross until it reaches the medulla, and then it crosses over and ascends. So the level of crossing is different for the two systems. The second important anatomical point is that the dorsal columns and the spinal thalamics are dispersed as far as their position in space. So we have the dorsal columns coming up through the dorsal columns in the spinal cord level, where the spinal thalamics are over to the anterior lateral system. So they have this spatial disparity until they reach the rostral pons, at which time they're in close anatomical proximity, and continue in close anatomical proximity until they reach the thalamus and then up to the cortex. Those two anatomical points will become clear as far as their clinical application as we go through and explore the neurological examination. Let's go back now and review how the neurological examination gives us a window. It gives us these X and Y coordinates with respect to the neurological system or the brain in the neurological exam. The mental status examination helps us to examine the cerebral hemispheres. Cranial nerves helps us to examine the brainstem, all the way from its rostral to its caudal extent. The coordination examination helps us to examine the cerebellum and its connections. We then have the sensory examination, which gives us two ascending longitudinal systems, which give us valuable Y points as well as X points, all the way from the periphery to the cerebral cortex. We then have the motor examination, in which we have a pathway that goes all the way from the motor strip in the cerebral hemispheres to the lower motor neuron, as well as lower motor neuron connections out to the periphery. There's one last component of the neurological examination, and that's gait. The gait examination helps us with important anatomical localization, but it also has contribution from almost all of the other components of the neurological examination that contribute to gait and to gait function. There are seven important pathological gaits that you need to be able to recognize, and we'll explore that in the tutorial on gait. Now, the rest of this tutorial will look at each section, will look at one of these 6 components of the neurological examination. Each part of the neurological examination, such as mental status or cranial nerves, will be divided into 4 sections. The first section for that particular module will be that of a review of the relevant anatomy and how that anatomy correlates with the neurological examination. The second section will be that of actually getting to see a neurological examination of a patient. The third component will be demonstration of abnormal findings in the neurological examination, and you'll be able to compare side by side the normal with the abnormal findings on that particular test or maneuver in the neurological examination. The fourth component will actually be a quiz so that you can make sure that you've got the major points and that you have the concepts that you need to take away concerning that particular module. At the end of the tutorial will be actual patient cases. Patient cases in which you'll be able to actually apply what you've learned as far as the neurological examination, in determining those levels and what systems are involved, to be able to have those X and those Y coordinates so that you can localize where in the nervous system is the problem, where is the lesion in the nervous system.